Dr. Haley is a medical consultant for the Southeast National TB Center in Gainesville and an adjunct clinical professor in the Department of Medicine at the University of Florida. In this role, she provides expert consultation to help other healthcare providers for challenging patients with TB and LTBI. She also conducts training and education to build capacity among public health programs, community providers, and healthcare facilities to manage patients and prevent TB transmission. Dr. Haley will be talking to us today on the cutting-edge topic of implementing the newly approved all-oral 6-month regimen of Pretonit, bedaquiline, and linezolid, known to you all as BPaL, for extensively drug-resistant or multi-intolerant TB, multi-drug intolerant TB in U.S. TB programs. And I'll turn that over to you, Connie. Connie, you're still on mute.
Yeah, I'm sorry. It was getting stuck there. Thank you. It's good to be here today. I'm glad to be talking about this topic. It's something that's very dear to me right now, and I've been spending a lot of time on it. So I'll start just by laying the land for where we are right now. And I think, as everyone's aware, some guidelines came out in 2019. They're the latest U.S. Guidelines for drug-resistant tuberculosis, and it was based on meta-analysis of individual patient data in patients who've received MDR-TB treatment. As of these guidelines, standard requires at least 4 to 5 drugs for a long duration of 18 to 24 months. It requires many, many pills, very hard to tolerate, and potentially toxic. And even more important, the cure rates and mortality have remained inadequate, especially in resource-limited settings, where they might not have access to some of the better drugs. I really like this graph that tells you kind of what the drugs are that we have available today and how they act. And the bottom line is that most of the drugs that we rely on for both drug susceptible and drug resistant tuberculosis, act primarily on the actively replicating population of microorganisms. INH, cycloserine, ethylbutyl, work on the cell wall. We've got linezolid and the injectables working on the ribosomes to inhibit protein synthesis, and the quinolones working on working on DNA gyrase. So really all of those are focused again towards that initial population where you have more organisms and they're actively replicating, building cell wall. Rifampin has always been able to shorten treatment if it's included for the entire 6 months and combined with PZA because of its ability to inhibit RNA synthesis. In other words, it acts on the persister organisms that are not actively replicating. And so that has been the core component of shortened TB treatment for drug susceptible TB. And without rifampin and drug resistant or treatment intolerant TB, we really are having to look for other things. More recently, bedaquiline has been a wonderful addition to the arsenal because it does not only go after the active replicating organisms, but it also attacks persisters through its effect on energy production. Also, clofazimine is considered to have some activity against persisters. It's not exactly clear how that works, but it likely has to do with membrane destabilization in the reactive species. And so that was where we were in the beginning of 2019. And here we are just a few months later in August of 2019, and the FDA approved a new regimen, BPaL. That's bedaquiline, Pretonit, and linezolid. And I want to emphasize again that though it says Pretonit was approved by the US FDA, it was actually the entire regimen. So Pretonit is not currently FDA approved alone or as an add-on to a different regimen. And the reason this was so exciting is that Pretonit has a mechanism action that goes after not only the actively replicating NTB organisms under aerobic conditions, but it also kills the non-replicating NTB organisms acting as a respiratory poison. And so in essence, you've now got 2 drugs in the BPaL regimen that are killing persisters. Linezolid, as you all know, also has strong activity against actively replicating organisms. And so, just by what we know about how the drugs work, it makes a lot of sense that this regimen has a lot of promise. So let's look at that a little more detail. So some of the mice studies were really helpful when they looked at nude mice and the mean lung colony forming units after 1 and 2 months of therapy with BPaL alone or in monotherapy or in combination, in different combinations. You'll see here that compared to the standard regimen of rifampin, isoniazid, and pyrazinamide, at 8 weeks, my arrow got moved when I moved my slides. If you look down at this bottom one, you have absolutely no culturable mice after 8 weeks. And the bedaquiline Pretonit alone were, good, but not quite as good as the RHZ. So it really is this BPaL, all 3 drugs with the addition of linezolid that seem to be very promising. And this other table will show you that when you look at lung colony forming units across that are accessed during treatment and also relapse rates, looking at, again, the individual drugs in different combinations, and then finally with the BPaL alone. BPaL really was the most promising in terms of sterilizing mice, not only after 3 months of treatment, but also 4 months after therapy had been stopped. There were 0 mice that had a relapse compared to 2 drugs alone and also 2 standard RIPE therapy. And so this was really, really exciting, and this kind of puts it at the top of the game. I'm really grateful to the TB Alliance for doing this because their goal to identify a universal treatment regimen, one that's short, safe, effective, and affordable, is really coming to fruition. And so if you'll see here, the NICS TB trial was sort of the first randomized clinical trial, that was looking at how this works in humans. And it really emphasized, again, the potent bactericidal activity, not just to Pretonit alone, but also in particular when you had all 3 drugs in combination. And again, bedaquiline, Pretonit, and linezolid together had the best bactericidal activity compared to any 2 combinations or Pretonit alone. And so the phase 3 trial looked at patients who were highly drug resistant, either XDR-TB or who had intolerance to MDR treatment in the past. It was conducted in South Africa when 109 patients. And again, these patients, it was a single-arm study, and these patients were very, very advanced, had very advanced disease, and many of them were highly treatment experienced. The actual regimen consisted of Pretonit 200 milligrams q-day with bedaquiline load for the first 2 weeks, followed by 200 milligrams 3 times a week after that. And then linezolid, the initial dose was 600 milligrams twice a day. And then later during the treatment trial, they changed it to 1,200 milligrams per day. And that dose, from my understanding, was chosen because that's the dose that's used against bacteria rather than mycobacteria. The treatment duration was for 6 months, although patients who had not converted their smears quickly and had prolonged positive evidence of prolonged cultures, they could be extended to 9 months. Another important thing to know about this trial is that Pretonit and bedaquiline had to be given exactly as they were prescribed. You had to have the Pretonit for 200 milligrams, and you had to have the bedaquiline after the load for 200 milligrams 3 times a week for the entire 6 months of treatment. But from the beginning, understanding that linezolid was potentially toxic, the decision was made that linezolid could either have a dose reduction after the first month, or you could actually stop it all the way after a couple of months. And so with that said, the patients, again, had significant disease. They had very low body mass indexes. About half of the patients had HIV, and these patients had been sick for a very long time, more than an average of about 12 months. But what was really phenomenal, and this is just like when we see the COVID vaccines being so highly effective, the primary outcome, a favorable outcome, which was looking at being culture positive at 6 months, was 90%. That is really outstanding. And among the XDR patients, even the highly experienced patients, they still had an 89% efficacy. And there were unfavorable outcomes in 11 patients. There were 7 deaths. Most of them were in advanced HIV patients who had other significant morbidity. They had 1 patient withdraw and only 1 that was completely lost to follow up. And I think as of now, there's 3 or 4 patients who've relapsed either at 6 months or past that point Some of those data are not out yet. When they look at the secondary endpoint of the median time to sputum culture conversion, it was incredibly short, 6 weeks for the combined total. For the XDR patients, of course, it was just a little bit longer at 6 weeks, but for the treatment intolerant patients, they had culture conversion just at 4 weeks. And that's just, again, just fantastic for drug-resistant patients. The downside, and what this trial also definitively showed us, that was with the current drug doses, in particular for linezolid, there was a really high proportion of patients who had adverse outcomes. Over 80% of patients had peripheral neuropathy, another 40% had anemia, a large proportion of patients had grade 3 or 4 adverse events on BPaL, including, again, neuropathy and other decreases in the hematologic parameters. And so that was really, really concerning. This is thought that linezolid is likely responsible for most of these, and all the dose modifications, and again, these were allowed kind of a priori by the protocol, but all the dose modifications were made because of the potential toxicity due to linezolid. And I also want to point out that 50 patients of 109 had to interrupt linezolid. Some were able to resume at the same or the lower dose, and another 33 had to permanently stop linezolid, with 27 were able to complete the remaining bedaquiline and Pretonit. They were able to live to do that. So in total, only 34 patients were able to maintain the original protocol with the 1,200 milligrams of linezolid and no dose interruptions. And I just want to comment that, a quote from the FDA briefing document was that the adverse events were as expected with this regimen, although they were generally manageable through dose modifications, and the majority of patients were able to complete therapy. But I also want to point out in the guidelines, that we're talking about now, especially in high resource settings, that we really need to pick a regimen based on high efficacy, but also the patient's ability to tolerate the drugs and to be able to safely complete and not have significant toxicity. The old adage of better deaf than dead really it's not appropriate anymore. So when we saw this, we had actually been using linezolid as a staple in our MGR treatment regimens for almost 4 years now. And we had sort of based our approach on our abilities to use the Florida State Public Health Lab to get linezolid MICs. And, it's understood that the MICs of mycobacteria are far lower than the MICs of bacteria. So typically less than 1, and what we really see is closer to, 0.25 or 0.5 MICs. So they're substantially below MICs for bacteria, which, suggests that perhaps lower doses would still be able to get well over the MIC and have adequate killing. So we began to use a linezolid dose starting at 600 milligrams a day. And again, that's in contrast to the niche trial, which looked at 1,200 milligrams a day. We have also the advantage of being able to get drug levels through Dr. Chuck Peliquin's lab, who's also one of the close partners working with us on this implementation project. And we were aware of evidence that suggested that if the linezolid trough could be kept less than 2, that it would indicate that patient had very much lower risk of linezolid associated toxicity, both peripheral and hematologic. And that has to do with mitochondrial dysfunction and damage that occurs at higher trough levels. And when patients' troughs are over 2, almost all of them tend to get toxicity of some sort. And even worse, some of those patients will not end up being able to have normal neurologic function. So some of the toxicity can actually persist, although some does go away. And the mechanism is too much to go into now, and I'm not the best person to go into it, but it's not a B6 dependent mechanism. We also aim for a peak based on sort of the standard expected ranges of 12 to 26 micrograms per ml. And so what we try to do is we have our MIC, we have our peak and our trough, we do a 2-hour and a 6-hour, and we try to make sure that our serum levels peak between 2 and 6 hours, somewhere between 4 and 16 times over the organism's MIC. And if the trough is too high, then we may increase the dosing interval. Or if it's that the peak is also too high, we might decrease the actual dose. And so I'll give you some examples later on in this talk. The other thing we do, we just have the benefit of being supported as a Centers of Excellence, that we are able to help all the providers and programs who ask for us to follow patients with them to really closely monitor patients clinically and with labs throughout therapy. And this is the paper I was referring to by Song, looking at a randomized prospective trial of 38 patients, looking at 2 different doses of 360, 600 milligrams of linezolid who had chronic XDR-TB. And they looked specifically at the mitochondria function, and they were able to correlate, again, mitochondrial function with development of adverse events. And in this patient, again, regardless of the dose, whether it was 300 or 600, if the trough was high, then those patients were much more at risk of toxicity. But if you could keep that trough below 2, much, much lower risk. And so it really demonstrated that using therapeutic monitoring was an important tool that we can use to help keep our patients safe. So I want to talk briefly about the implementation in the U.S. I'm only going to focus on patients that I've personally been involved with through my center, the Southeast National TB Center, as well as 4 patients in Washington State who graciously asked us to, to show them what we were doing and then follow along with them afterwards. And this is just a map where there are also patients being treated in other parts of the U.S. outside of my center that are not included in this, but I thought it's good to see that we're starting to really scale up implementation of this regimen. So as a TB Centers of Excellence, we provide longitudinal consultation for any patients, challenging or otherwise, that on request. And so since the FDA came out, we've been actually implementing BPaL and monitoring them, as I described, very closely. And as I mentioned, we get labs, and we usually try to send isolates to both CDC and to Florida, so we can have 2 labs that can get us both molecular drug susceptibilities, preferably immediately as the patient is being diagnosed, and as well as growth-based drug resistance testing with critical concentrations at the CDC and using MICs through the Florida lab. And we document all of these in a database. And I'll be honest, it's not a great database for tracking patients and letting you know what's due and pending. So I set up an Excel spreadsheet to try to track these and be careful. All these patients, the one thing I really want to say is that the TB providers and SNTC talked about whether we thought BPaL was appropriate or if something else was. There was always a patient decision. The patient was always educated. The patient was always encouraged, to think about what would be best for them. We told them the pros and cons of both the traditional longer regimens and the BPaL regimen. The programs were amazing. They handled all the logistics. SNTC developed the ability to get drug procurement, especially challenging when you're talking about bedaquiline and Pretonit and patient assistance. The first patient we treated, we didn't even have Pretonit available. We had to get it directly from overseas through the TB Alliance, and we were very, very grateful for that. And then, as I mentioned, we developed patient-specific monitoring, and that requires not only that we say, okay, this is how we do it in our Centers of Excellence, but we help the programs and the providers in the local setting be able to do what's needed to keep the patient safe. So we provided a lot of hands-on guidance and education. We would get their isolates tested in our lab. We would take their direct patient clinical specimens and bring them to our lab for testing if needed. We provided mobile apps for QTC monitoring so that if they were out in a rural area and patient couldn't come into clinic, we could still follow the QT intervals. And we also provided therapeutic drug monitoring for all these patients. And because we didn't have funds for that, we sought funds through the Virginia TB Foundation, and we're very, very grateful. We absolutely could not be providing this level of patient care without them. So just to summarize our patient experience so far, and again, these are only patients in Southeast National TB Center in Washington State, and we have a few that are queuing up about to get started that are not included. But generally speaking, these patients were about 43 years old on average, ranging from 17 to 83 years of age. Most were male and born outside of the United States from a variety of different countries. We only had 1 patient that was HIV infected. We had 2 patients that were rifamycin intolerant, and while that was not done in the NICS trial, we felt that these 2 patients had, who came up after we'd already a good bit of experience with BPaL and absolutely could not use a rifamycin. One had a severe allergy and one had severe hematologic toxicity and was just not able, she was looking at a 18 to 24 month regimen just because of losing rifampin, and we really felt that BPaL was the best thing for her. We explained the lack of data in patients with drug susceptible to TB, and both of these patients opted for BPaL, and both have done amazing. We had mostly MDR patients, some pre-XDR, and then the one XDR. So again, compared to the NICS trial, our patients were really not nearly as sick. We did have extrapulmonary patients included in our patients, whereas the NICS was predominantly pulmonary, but we again had these patients come up who had, multi-drug resistant TB, couldn't be cured with a short regimen, and we really felt like this all-oral regimen was the right thing to do. And again, patient consent. So I'm happy to say, as of now, we've had 20 patients complete the full 6 month of BPaL. One is, well over a year out, and some of the others, have been out for quite a while, and so far, no one has relapsed. There are 7 that are still on treatment and all still doing very, very well. We have no concerns with that. 6 patients had to have treatment interruptions for various things, and all were able to resume BPaL without any trouble. The reasons included 3 patients who were short of breath, had chest pains and palpitations, and they had huge workups, including, cardiac, rule out MI. They had evaluation for pulmonary emboli and other things, and it really boiled down to what we think was anxiety. And so they were able to get back on the BPaL and did fantastic. And all of those patients, I believe, have finished now without any adverse events. We had one patient that had an elevated ALT up to 450, and that patient also developed COVID shortly after we started BPaL. And so they had a pause for a while, and when they improved, we started BPaL back up, and she's doing fantastic. One patient had their BPaL held. It was more of a miscommunication. She had a totally normal QTC, but her potassium went down, and so her meds were held, and she went back on it. She's also doing fine. And then right now we have another patient that we're evaluating that seems to have an increasing lung mass. She's got a heavy smoking history, and we actually think that she's not relapsing with TB. We think that she's got cancer, and so she's actually gone back on BPaL as well. And I talked about some of the complaints. We had 6 patients that had absolutely not one complaint. I'm sure that there was something, maybe they just didn't mention it, but compared to even standard treatment with RIPE, that just was really notable. We had no patients that had QT interval that was prolonged using the measurement of over 500 milliseconds. 6 patients had hepatic issues. 5 had elevated liver enzymes above 3 times normal, but they were all asymptomatic. 1 had a bilirubin up to 1.5. All of that resolved. None of them had a problem or had to stop therapy. Hematologic issues, we expected more problems, actually we didn't, because we've been using linezolid for a while, but we were monitoring, and we really found very few patients that had a problem. We had mild to moderate decreases in hemoglobin and platelets. 1 patient that had severe hematologic toxicity on RIPE and quinolones and everything else they tried to throw out, or actually did better when she got onto BPaL. Again, the neurologic issue is something we were really concerned about because of the NICS trial results. And there were a couple of patients that had unusual paresthesias of their face, fingers, toes, and forearms. And those were among patients where there were issues with getting their linezolid troughs. And so I'll show you that in just a minute. 1 patient had significant baseline peripheral neuropathy, took BPaL, was closely monitored, and had no problems. And then just little things like anxiety, diarrhea, GI nausea, upset. I mean, again, it really wasn't very significant. And many of our patients said, I can't believe I feel this good, including a young woman that was a treated MDR TB patients in India, and she just kept raving that she couldn't understand. She thought for sure that she would be sick for so long and feel so terrible on treatment based on what her patients had experienced in India, and she just was just so happy. And but one thing we noticed was a little signal with anxiety, and one other thing we noticed was acne. But again, those were things that are not that uncommon, and acne had been reported also in NICS. This is really busy, and what I really just want to show you is, as I mentioned, we use drug levels, and I'm going to pull that out in the next couple of slides, but I want to show you mainly here. The patients who developed the neurologic problems had higher troughs. So this patient started off with a lower trough, and when these numbness of the fingers and toes developed, the trough was actually found to be high, but unfortunately it was towards the end of treatment, and so it hadn't been changed, but all this resolved when treatment stopped. Another patient who had a trough of 2.4, had vague tingling of their face and scalp and numbness in their arms and their eyes. It was very odd. Unfortunately, this was also during COVID. So again, patient was supposed to get follow-up labs and they didn't happen, but patient's doing completely fine now, everything resolved. Down here, you'll see there was one more patient that had had painful in their fourth and fifth toes. It was a transgender individual who wore very tight shoes to work and had a lot of anxiety. And he also had a trough that was acceptable when treatment was started, and his dose had been increased. But again, the trough was a little later. And so it all went away, though, after treatment was stopped. And so I really, that's kind of some good examples of the other patients who had treatment altered, even when we were going up to higher doses, and they continued to have low troughs, less than 2, 1, 1.4, 1.5, 0.9. They all did well, and none of those patients had any toxicity of neuropathy or hematologic issues. This is just another slide kind of showing that same thing. Even when we increased the dose to 900 milligrams, we would get a higher peak, and then we would change to the dosing intervals. So we would go to every other day, and the trough would come down. I'm going to just pull out
Connie,
a few of these.
I'm going to ask you to summarize if you can, because
okay, great. I'm sorry I didn't hear my buzz. So these patients did great, and there's still so much that we need to know. We need 2-year follow-up of our patients to make sure that none of these patients relapse. We need to find out what is the safest linezolid dose. We don't sacrifice efficacy. Populations like children, pregnant women, patients with underlying liver and renal disease, and extrapulmonary disease. These are all unanswered questions. And so in conclusion, please seek expert consultation for TB complex patients. The Centers of Excellence have been, designated in the U.S. to be able to help you and help provide additional resources, whether it's personnel or other things. We now have a grant that enables us to provide linezolid therapeutic drug monitoring for any patients in the U.S., no matter what state that you're in. And thank you to CDC and the Virginia TB Foundation. And, please, published studies are only useful if they're implemented into practice. It takes 17 years on average for most published clinical data to be put into practice, and that's just too long. And so we're really glad that though we were tentative doing this, we were following them closely, and so far so good. And please feel free to reach out to me with questions, and I'm glad to help you manage patients and get these resources I mentioned. So thank you to my colleagues as well.
Connie, thank you very much.